Good morning, ladies and gentlemen, and welcome to today's webinar. Sorry, we started a bit late. We were to begin at 11, and we are 6 minutes behind schedule. Today's webinar with a big topic is SHA working? I might read it again. Is Kenya SHA working as desired? An assessment of issues and implementation gaps. For those joining us for the first time, welcome to the Institute of Economic Affairs. The Institute of Economic Affairs, popularly known as IEA Kenya, is a think tank that provides a platform for informed discussions in order to influence public policy. We also undertake research and conduct education on key economic and topical issues. Our main intention is to utilize the outcomes of the research for policy dialogue and to influence policy making. This webinar has been made possible through funding by FCDO, which has enabled us to continue implementing our projects that aims to strengthen fiscal transparency and accountability and advance an informed political agency of citizens on fiscal governance for better development outcomes. Having said that, of course, for those joining us for the first time, you will notice that your mic and cameras are muted. It's for the purpose of proper administration of the discussion. However, in the event you need to raise a question or you want to ask something as we go on through the presentation, you are free to use our chat box. Please, you're free also to use the Q&A. And after the presentations, please, we'll be open to a plenary session where we'll be able to ask our questions and have to discuss this important topical issue. Having said that, my name is Jotham Chacha. I work for the Institute of Economic Affairs. And today's webinar is made possible through the units of public finance management, one of the units within the Institute. Let me welcome my colleague, John Mutua, who will be taking us through the remainder of the sessions. Welcome, John, and thank you.
Thanks, Jotham. I hope you can hear me. It's my camera. Jotham, can you hear me?
Yes, sure, John. I can hear you.
Yes, John.
And you can see the slides, eh?
Yeah, sure.
I don't know what's wrong with my camera. Just 1 second. Something wrong with my
Yeah, I can see the first
John, you
slide.
can proceed.
Are you able to see me?
Yes.
Okay. So thanks, Jotham. So I will take us through this analysis. Actually, this analysis is a contribution from my colleagues as well. So Jotham, who is moderating, Jotham, Chacha, Pauline, and Raphael Moya have also contributed to this. So anyway, so I'll take us through this. I'll take about, 35 minutes or so to take us through this study. So we were asking ourselves, the questions that we hear from the media is whether SHA is working, whether this Social Health Authority is working. Of course, we've included here as desired in the fact that it was inaugurated on the 1st of October 2024. It's obviously working, but the question is whether it's working as desired or as intended. Now, to be able to answer this, question, one can actually dissect it from various angles. But what we decided to do is to assess it from a perspective of the components, the key components that comprise any social health insurance scheme. And so what we'll be doing is to assess the design gaps as well as the implementation gaps. And just to mention, what we did was basically rely on, because this was a desk review, rely on available information online, media reports, government documents, and so on. So that formed the basis of our sources of data. So what we have is actually limited to what we are able to find from the various documents, fragmented documents, online, largely online. So the outline, I'll share some background. Also mention why the shift from the defunct National Health Insurance Fund into SHA. Then obviously mention the objectives, which I've just started with, and then go straight into the assessment based on the 4 key components of any social health insurance scheme. Then summarize this or provide some takeaways and recommendations to as a way of concluding this. Now, universal health coverage is defined in many ways. WHO actually provides they provide the definition of universal health coverage, and these are actually also picked from the Ministry of Health. And I was trying to remove. Not able to see my slides.
Yeah, okay, John, you may proceed. You're on the background slide.
Yeah, but just one. There's something wrong with my. Steve can. But anyway, so universal health coverage entails three things. The first one is actually about the people, their ability to access services. So the second one is on the quality of health services and whether they're able to access these health services without suffering financial hardship. So that's what universal health coverage is, and it entails a full continuum of essential health services, from health promotion to prevention, treatment, rehabilitation, palliative care across life course. Now, this is actually a goal for many countries, and integral in this goal is actually the question of health financing, which is an important building block for any other system. Now, so what you see here is basically a schema of a general of various sources of financing to any typical healthcare system, and they obviously comprise government funding. In our case, it's about 40 to 50% of total health expenditure, and then obviously government funding through taxation. And then you can see there are various other sources. There is a premium health insurance actually. So contribution, where people pay a contribution or premiums, in our case household or individuals. Then in some cases there's also what is called earmarked taxes. So there could be some specific taxes that are targeted towards delivery of health services. And often these are based on what we call the sin taxes, excise duty, whether it's on alcoholic beverages, tobacco, etc. Then in some cases, we also have community-based health insurance. I think in Kenya, both Makueni and Murang'a have community-based health insurance. So this is a typical schema. And then obviously there's an important one here, out of pocket expenditure. So when people go to seek healthcare, if obviously you don't have health insurance, then you basically have to pay out of pocket. So this is a typical a schema on health financing. Now the goal of the government through the ministry is actually to reduce out-of-pocket expenditure, which is quite high. It's about 20% plus. That's based on the most recent national health accounts. And for many countries, the pathway towards universal health coverage, which is actually the goal for many countries, is through health insurance, what is called social health insurance scheme. So that's the pathway that many countries use towards realizing UHC. In our case, obviously, we've had the National Health Insurance, initially Hospital Health Insurance Funds from in the 1960s. And the government has had this long-standing desire to move into a social health insurance scheme. So, because this helps in terms of pulling resources together and helping or reducing the burden that individuals or households would get into through when they are seeking medical care. So this is a scheme that is used by many countries. Obviously, health insurance is a subset of general health financing. So that's the schema. Now, in our case, there's been a lot of debate on this question of whether SHA is working or not, and there are always recurring questions from the public why we transitioned from NHIF into the defunct NHIF into social health insurance into SHA. There are also other recurring questions related to the question about revamping. Instead of having moved this, why did we revamp the defunct NHIF? Now, just to mention some of the things that may be able to respond to this is that first, the NHIF since it was established in 1966 has undergone various amendments. But even with these many amendments, certain challenges prevail. So one of them is obviously the coverage has been very low, 21%. That's for NHIF. The NHIF has again been persistently flagged for audit queries. The coverage is actually skewed and largely favors, skewed in favor of inpatient services. We also had actually fragmented schemes, Eduafia, Linda Mama, which obviously created a bit of inequality. And then there's this term on reverse cross subsidy, where actually with NHIF, whereas it's expected that the healthy will support the sick and the rich will support the poor, with NHIF we've actually seen the reverse, where the rich were actually benefiting quite a bit. So that's what is known as reverse cross subsidy. And then the other challenge was obviously skewed reimbursement that was favoring private sector facilities. So these are recurring challenges that NHIF, the defunct NHIF, faced. and hence the need to transition into social health insurance. Struggling to move my. Now, so this is actually from the Kenya Federation Authority, and it captures the social health insurance infrastructure or architecture. And the background for social health insurance is we have the Social Health Insurance Act. So it provides the general institutional framework for social health insurance. It obviously establishes the Social Health Authority, SHA, and SHA actually manages 3 funds, which is quite different from what we had with the National Health Insurance Fund. So we have the private primary healthcare fund, and emergency chronic and critical illness fund. So these 2 are actually tax based. And then of course we have the famous SHIF, Social Health Insurance Fund, that is contributory. So this scheme actually provides quite a bit of detail based on what this law, Social Health Insurance Act of 2023 provides. Now, this I mentioned, obviously, so we are asking ourselves, in order to assess whether SHA is working as desired or as intended, we followed this method or approach. Now, there is a study that shows the key components of any social health insurance scheme, and this you can see them here. There are actually 4. The first one is financing sources, then we have risk and resource pooling, strategic purchasing is the third, and then administration and management is the fourth. So these are the 4 components of any social health insurance. And they are useful in terms of just trying to basically respond directly to this question, and they provide this foundation that is useful in order to redress any emerging issues, either from a design perspective or even in implementation perspective. Then of course we're going to use this study to advance issue-based politics around social health authority or social health insurance scheme in Kenya. So I will go through each one of these 4 components very quickly. So Jotham, let me know if I'm slowing down. Now, of course, the 4 components each have sub-components. Now, starting with the sources of finances, what we see, and this is actually aligned to the 3 funds that SHA is managing or running. The first one, what we see actually, and is quite commendable from a design perspective, is that SHA is actually, the sources of funds are multiple. So as I mentioned, we have SHIF, which is based on contribution, or you finance through contributions, and these are premiums that are deducted from payrolls for the formal registered SHIF members as well as the informal. Of course, the rate here is at 2.7% of gross salary, and for those that are not salaried, that is determined through a means testing tool. Then for the other 2, as I mentioned, these are tax-based. So these are actually financed through the exchequer. So there's a transfer that is made to the Ministry of Health. And when you go through the Ministry of Health budgets, you'll see those lines for primary health care fund, as well as emergency chronic and critical illness fund. Now, the law provides also that there are other sources of funds, but these are actually on paper. So to date, we haven't seen any other source of fund, whether it's grants, donation, etc., coming to support these other 2 funds. So that's only on paper, and it's highly skeptical whether that will materialize. Then the other thing to look at is whether this, from a design perspective, whether the three funds here in our case are pro-poor. So we see the two PHSC fund and ECCIF are actually tax funded, but they comprise both progressive and regressive taxes, the VATs, income tax, excise duty, customs, etc. But they are not based on any earmarked taxes. So from that perspective, we cannot say that they are pro-poor. Then for SHIF actually from a design perspective, there is a subsidy for indigents. This is for poor and vulnerable households at 600 shillings per household. And then there's another program actually for persons with irregular incomes at 880 shillings per household. So again, from a design perspective, that's actually a tick. However, of course, this is a flat rate. And in terms of strictly being pro-poor, a progressive, a tired rate or a graduated rate would be more responsive in terms of being pro-poor. Then the other aspect is actually on the feasibility of collection. So for the other two funds, that's relatively easy because they are tax-based. But then the main challenge with the SHIF is that whereas for the salaried it is quite easy to collect, that's the viability of collection, because this is a deduction straight from payrolls that is then remitted by employers to SHA. In our case, we have a sizable informal sector, and collecting from the informal sector is difficult. So we'll be getting into that. And then finally, on the question of sufficiency of resources, so the simple answer is that the resources to date are not sufficient for the three funds. And obviously, as you can tell, for SHIF, the main challenge is because of the difficulty of collection from the informal sector. So I've gone through this. Yes, from a design perspective, yes, SHIF is actually pro-poor. But we don't have details of, there is a target to reach 2.49 million households, but it's not very clear what the government has achieved so far, because we tried to look for documents just to confirm what the government has achieved so far, but that we did not come across that. Then the other thing to note is, however, the SHIF subsidy program, the effectiveness of this program is actually undermined by two or three things. The first is that the mean testing tool is actually weak in terms of there's poor targeting in beneficiary identification. So the challenge we have is what is called inclusion-exclusion error. So whereby you find inclusion of people who are not supposed to benefit from subsidy, so the rich, and in some cases there's exclusion of the people who are supposed to benefit. And we also have cases where there is exclusion due to lack of identification of documents. So whereas, yes, the program exists, but in practice, there are certain challenges that actually undermine its effectiveness. And then the third one is obviously funding gaps. Given that this is a program that is financed from the exchequer, it is actually competing with other programs, whether you're talking of education, security, and so on. And that's why to date, it experiences budget cuts and the funding is not sufficient. So I mentioned about the 2.75 flat rate. It's not progressive. These are proportional rate. In terms of being completely poor, are more tired. Something similar to what we have with the pay-as-you-earn income structure would be termed as being progressive and pro-poor. So the rest, for the other two funds, as you can see, yes, not pro-poor, but of course, PHC fund actually benefits all registered Kenyans. However, for one to benefit from ECCF, with the exception of emergency services, you must be a paid up chief member. In terms of feasibility of collection, yes, we currently have technical and administrative gaps. So for instance, in terms of income verification, there are also questions about digital access barriers. So particularly for households in the rural area, they have challenges in terms of accessing the SHA system. And for them, beyond registering, obviously, they have to sign up for the means testing. So that's a bit of a challenge. And so when it comes to payment of their contribution, that is also a challenge because of the digital divide challenge. Yes, there's actually, in terms of contributions or making contributions, the law actually provides for a penalty, but to date, enforcement mechanisms are weak, and we'll get into this later. Then the other challenge in terms of feasibility of collection is the government is actually struggling to make or comply or in terms of making premiums for the indigents for the sheep subsidy program. Now, on the question of whether the funds are sufficient, the simple answer is actually no. And we have evidence to confirm this. Now, the best way to tell whether funds are sufficient is obviously compare costing studies or fiscal space analysis studies. And maybe these studies are actually available for internal use by SHA or the Ministry of Health, but they are not publicly available. So in terms of the projected revenues vis-a-vis the cost of the benefit packages or purchasing or paying for the services. So we don't have the benefit of that study. But from interaction with various budget documents, particularly the health sector reports, there are things, it actually shows that, for instance, that there are funding gaps. Now, if you look at the small table there, shift in 2025, 2026, the requirement was about 100.7 billion, but the approved budget was 81.8. So you can see the gap there and the shortfall. And actually the same applies to the other funds. And the biggest gap actually is with regard to the ECCIF. And again, based on some of the information that we gathered is that reports actually, this was from the SHA CEO. She mentioned that monthly collection from January to October was about 6.5 billion. But if you look at these amounts here in terms of what is required, this comes to about 8.3 billion. So we're obviously collecting less than what is needed or required for each of them. But this is particularly for shift. Now, this shortfall in the revenues that are collected is actually attributed to largely two things. The first one is the low retention rate. So retention rate basically is a comparison between the number of registered members vis-a-vis those that are actually contributing, the active membership. Now here, again, just based on the information that we gathered, the 27.3 by November 2025, the total number of registration was about 27.3 billion. And right now it's actually upwards of 28 million. But all the information that is covered, there isn't any specific breakdown of the registration in terms of those that are salaried, the number registered that are from the informal sector, and the active membership. But there are some things that we used in terms of coming up with this computation. There's a figure that's quoted by the media, and we used that, and we were able to come up with these computations. And what they show is that the overall active membership, so the active membership here is basically is 4.9. So 4.9 divided by 27.3, you get a retention rate of 18%. So basically, of the 27.3 million registered individuals, the ones who are paying or contributing consistently to SHA is 18% of that number. But then you can also break down the retention by those that are formal members vis-a-vis the informal members. So the active informal members in our case is basically, you can see the total registered members from the informal sector are 23.3, and you have to subtract the 4.9, the total active membership from the total active formal members, and you'll get to 0.86. So about 860,000. There are about 860,000 members from the informal sector who are actively paying. So actually, the retention rate is significantly low for the informal sector members or enrollees. So that's the major, one of the factors contributing to this shortfall in revenue projections. And then the other one is obviously related to the means testing tool. Now this tool, there are a number of challenges, and I think the main one to just mention is that again related to this, there are people, because of various challenges, whether it's the digital access challenges, people who are registering but not signing up for the mean testing. But I also mentioned the mean testing tool as largely what you call the inclusion exclusion errors, that is also reducing the accurate payable premium that one is supposed to pay, particularly for those that are in the informal sectors. So these two factors actually end up reducing the financial sustainability of SHIF, and this is what is actually leading to delayed payments, ultimately affecting service delivery. So moving on to the second component, which is called pooling, and it comprises two components: what is called the level of compulsion and risk pooling. Now, a good design of a social health insurance scheme should be mandatory. Now, we know the challenges that Kenya has faced for all these years with the defunct National Health Insurance Fund is that it was only mandatory for the formal sector employees. Now, obviously, that was not sufficient to be able to pool resources together in terms of financing healthcare. And hence, the need to, based on the lessons that we learned, or the country learned, or the government learned, this current design of the SHA is actually mandatory. So that's actually a plus. This obviously helps with the predictability of resources, in terms of financing universal health coverage, but it also ensures that that no one is left behind. The main gap or challenge with this is that whereas the law provides for lump sum annual contribution, there has been a lot of complaints, particularly from the enrollees in the informal sector. Given obviously affordability concerns, Kenya's poverty levels are quite high, about 39.8%. So many Kenyans actually are struggling to be able to make that annual premium payment based on obviously what the mean testing shows in terms of the ability to pay. And hence, the government actually responded to this by introducing what is called a flexi financing option, Lipa Sha Pole Pole. So that was actually the response. But the main challenge we have again with this, so this actually is supposed to help with payment in installments, whether it's daily, weekly, or monthly. But again, there are questions about operationability of this. So whereas from the ministry or even government reports from the Ministry of Health show that the system is operational, there were people who were interviewed saying that they have challenges going through the system. There are breakdowns and downtimes and so on. So that's basically the main. And so when the contribution, as much as yes, we have mandatory participation and there's this tool, but again, that has actually affected the pooling because we have the system is actually as what is called, I mean, this inconsistent contribution, and as I mentioned, compliance rate so far is 18%, even with government's response. So this is quite low, and this obviously affects the pooling of resources. Then the third component, so I'm trying to go a little bit fast, is what is called strategic purchasing, and it entails what is called the benefit package and the provider payment mechanism. So it basically provides the bridge between mobilization of funds or resources and the delivery of services. So this is what helps with the coming up with an optimal mix in terms of the services and the providers towards maximizing Kenya's health priorities. So as you can see from this small schema, so that's basically what strategic purchasing is. Now, again, there's a shift, whereas in the past with the defunct NHIF, it was more passive, but this one is now more evidence-based in terms of in the design of the benefit package, and I'll mention what that is, but also in the accreditation of facilities or contracting of facilities. I don't know that I should show this, but basically, if you look at the benefit package, so the benefit package is quite comprehensive. So, and you can tell that from the scope and the depth of the services that are offered. And so there are services for each of the three funds, and the package developed obviously by the ministry provides information in terms of access point for whatever service. It also shows what is called access rules, and obviously the corresponding tariffs, or what each service, the cost for each service, or what the insurance is actually supposed to pay. I wanted to show this, but I don't know whether but one can click, you can actually get it from the ministry. It's quite huge, but let me just mention one. So for instance, it provides information on outpatient services under PHC, the services that will be financed from PHC. And for PHC, we know, of course, there's a outpatient screening, optical services, and other inpatient services. ECCIF, we have ambulances and emergency, and then there are also critical illnesses, chronic illness, dialysis, therapy, kidney transplant, etc. All those fall under ECCIF, whereas for SHIF, it's largely for specialized healthcare. We have renal, medical imaging, surgery, maternal, obviously, services. But those you can actually get them straight. I can show this if there's any question. So there is a broad package that's quite detailed, and it's comprehensive. But no doubt that actually what one sees from this is that it's quite ambitious. And obviously from this ambition, there are certain risks, because if you have a package that outpaces financing, that outpaces financing and the system capacity, then there are risks that will arise, and we'll mention this as we go on. So some of the challenge or complaints from users, patients, as well as the service providers, because the strategic purchasing encompasses all this, is that when you go through the benefits package, many share tariffs do not actually reflect the real cost of service. So there's a question of underpricing of services, and there's been complaints about that, whether it's your optical services, whether it's dental, etc. And this is a major challenge with regard to private health facilities. Then there are also questions around the fact that these tariffs are actually quite standardized, and that they do not cover cost of medication and consumables, and also the fact that they ignore cost variations by location, facility level. So we have these facilities from level 2 all the way to level 6. The question of patient volume and caseload. So these tariffs are actually standardized, and so they do not respond to these variations. And so what ends up happening is that this is actually leading to some providers actually limiting the services, because if a tariff does not meet the actual cost of the service, then some providers would limit services. Some would actually ask patients to co-pay, either pay additional top-up, or some are actually opting out from the contract with the SHA. So those are some of the things that are happening. So some kind of a rationing and so on. So these are challenges that are being experienced so far. And obviously, the benefit package is quite expensive, and we know that the resources, projected financial resources, are not sufficient, obviously, because of the narrow fiscal space. We know that Kenya has a huge debt that is the government is servicing, and that actually leaves very little resources to go towards investing into these funds and provide towards providing services towards the realization of UHC. Now, the provider payment mechanism is you can see from this small table, this is about how the services will be purchased. So there is it's a bit technical, but there are different ways in which you can see each of these funds here. So if we take, for instance, maternity, newborn, and child health. So this is actually supported by SHIF for levels 4 to 6, and how they purchase is based on what is called a case based. So there are different provider payment modalities. I know the one that is common out there is the capitation, but that has actually changed. I don't know that it has changed in practice, but as you can see, for PHC, which basically this caters for, these are free services at the primary health facility level, outpatient, and there are also other maternity, newborn health services here. Outpatient services are actually paid through what is called global budget capitation, which is a bit different from the normal capitation. But I mean, I can always provide those in the actual report. We have the definitions of those. And then for the other services, you can see the common one is called fixed FFS. Remember, fixed fee service, which is actually it entails the provider charging a fee for each service offered to members of health insurance. Whereas capitation is obviously a fixed fee payment to a provider to deliver a set of services. So this is a bit technical, but it's a blended payment mechanism. So FFS actually stands for fee for service. So a blended approach is actually what many social health insurance schemes have adopted, and it's a good way of ensuring that cost is contained and that it ensures obviously quality of services are provided, because that's the entire the objective of the PPMs in terms of design is to optimize the reduction of cost. Now, depending on the mode of payment, there are obviously certain pros and cons for each of these in terms of just ensuring that resources are sent to facilities on time and so on. But the major thing is to ensure that there is also reduction of any of fraud. Now, the fee for service, as you can see here, it's quite common and shift for many of these healthcare services. Now, the main challenge with that is it's actually prone to fraud. So depending on the mechanisms that have been set, SHA has to ensure that it has proper oversight mechanisms to reduce on the causes of fraud. But basically, strategic purchasing entails the design of the benefit package and having a mechanism that would ensure that there is equity, there is efficiency, and reduction of costs and fraud. But in our case, as you can see, for SHA, there are a number of challenges, and actually, as much as SHA has invested in a huge digital backbone through the Digital Health Agency, there are still many cases of fraud that have been flagged, and these were actually this I got from the media. And the common one is that conversion of outpatient visits to inpatient, so as to bill for to claim for more, basically. There are also other cases of multiple billing and ghost patient. That's collusion between facilities, again to claim for the same patient. So there are different multiple fraudulent practices that SHA has been experiencing, and I mean credit to the system in terms of being able to flag this out. But the challenge is actually to plug them these fraudulent cases. So obviously we know that SHA is still evolving, is still maturing, and hence some of the challenges that it is experiencing. So finally, we have the administration and management of SHA, and this basically speaks to two things. It's about the oversight and management infrastructure for SHA as well as it also assesses the administrative capacity. Now, if you go through the Social Health Insurance Act as well as the regulations, you can tell that it's very clear, and it actually incorporates lessons learned from the defunct or challenges that NHIF experienced. And so there is part 2 actually provides for an institutional accountability framework whereby there's a board that the SHA reports to, and there's a clear financial accountability. So SHA obviously shares its accounts with the Auditor Generals. These accounts are actually forwarded to the National Assembly. So there's a clear mechanisms for both institutional and financial accountability. I think the main challenge with SHA in the way it is designed, and maybe that's a deliberate design, but it is both the regulator and purchaser of health services. So SHA sets tariffs and so on, and also purchases services. So the main challenge with this, in line with the principles of separation of functions, is that this obviously raises conflict of interest and accountability concerns. So for instance, the implication is that it becomes very difficult, or SHA would be reluctant actually to sanction facilities that have been contracted or empaneled by them. And there's also the risk of capture by powerful providers. So those big private providers can influence whatever SHA is, and actually make it difficult for them to be sanctioned. So those would be, and even just enforcement of quality standards. So you are both a regulator and a purchaser. So that also is actually compromised given this arrangement. So obviously the mitigation factor for that is the need to have a robust oversight mechanism. But the best in terms of design is to separate the two functions. So in our case, maybe that's something that SHA should consider in the long term. Then there are a few other challenges. So quickly running through this, we still have challenges in terms of coordination between national government, county government, SHA itself, and so on. So obviously all those challenges end up affecting service delivery. There is inadequate health infrastructure, and PHC, primary health care, is actually affected the most. So in terms of the referral pathway, if PHC is not working or is not resourced properly, so patients tends to bypass that and go to seek care from facilities up there, the tertiary facilities, and that actually has a bearing on the social health insurance scheme, because what that tends to do is actually increase claims on SHIF and ECCIF. So any social health insurance scheme as designed as ours is, as Kenya's is, has to ensure that PHC is well resourced. So far with registration and contribution, actually the biggest positive for SHA is in the number of people who are registered, the infrastructure for registration, etc. There was a transition from OTP to biometric, so the success rate is currently 74%. So obviously that transition also has helped with the reduction of fraud. But again, there are challenges with the biometrics system. And then the main challenge in terms of administration and management is with regard to claims and reimbursement. There are many cases where facilities are complaining of delayed disbursement. Obviously, that affects the liquidity and survival actually of facilities. There are many reports. Rural urban private health assurance conducts surveys every so often. And for instance, between Jan and March of last year, they show that the SHIF claim settlement rate was quite low. 34%. So this is actually claim what has been submitted for as claim versus what has been paid. From the Office of the Control of Budget, by the end of 2024-2025, the approved claims were totaling about 20 billion. This is for public health facilities, and what was paid was 12.5 B, and you can see the balance of 7.5. And based on an interview from the SHA CEO, she mentioned that out of claims of amounting to between 80 to 82 billion, that is by September 2025, 13% of them were rejected, largely due to fraud. Yeah, so there's lots of challenges regarding management of claims in terms of the system itself, but also some of the things that explain the rejection of claims is the challenges, the user challenges. Facilities are, when they are submitting their claims, they're supposed to attach all the supporting documents, theater notes, etc. And they need to also know how to use the system, but there are challenges. And actually, a survey that was done by Rufa shows that there is the demand for training is an indicator of this challenge of using the system. Even with a heavy investment in digital health, the health sector ICT is still fragmented. So for instance, claim systems are not fully interoperable with the facility electronic medical records or county systems. So we still have those challenges in terms of streamlining and harmonizing the ICT system. So very quickly, my takeaways is that yes, the SHA system is still evolving and maturing 1 year, 3 months down the line, and hence some of the gaps in terms of its effectiveness. There is significant funding gaps to SHA due to low compliance rate, fraud, etc. So obviously this destabilizes the funds and makes them vulnerable. The benefit package is ambitious and expensive. There is a crisis with the claims and reimbursement. This has an impact on facilities and service deliveries. And obviously, and finally, obviously, we still have the question of operational and capacity gaps for the health system. Connectivity is still suboptimal. We have staffing shortages, particularly on special skills, whether it's within the facilities, but also within SHA itself, like in terms of the number of officers specialized in actuarial skills and so on. So based on all these challenges, the biggest issue is financing. So here, there are a couple of things that needs to be done. They are related to enrollment mechanisms. So there is need for outreach and mobilization. So SHA needs to expand that and enhance its outreach so as to ensure that beyond registration, that members actually sign up for means testing, particularly those in the informal sector, because that's where we have the biggest challenge. And there's also need to strengthen the mean testing, maybe adopt a hybrid target targeting. So this looks at other things beyond just the household characteristics. There are questions of geography, demography, etc. So it's a more superior testing so that it's not just a means testing. There's also some kind of a community validation. So that system needs to be strengthened. And this will actually improve on accuracy in determining payable premiums and reduce on these inclusion-exclusion errors. Yeah, so I mentioned obviously contribution is based on feasibility of collection. So again, even with the penalty, maybe there's need to ensure that there's a graduated enforcement mechanism where maybe people are warned first before the penalty is applied. There is also need to strengthen, which I mentioned, the digital enrollment and ensure functionality of the flexi financing option. So this will improve the compliance rate. So even for the subsidy programs, payment by government is also lagging behind. There's also need for the government to clear NHIF debt. So I think they mentioned some approach in terms of prioritizing on NHIF debt, but I haven't seen a report of where the government is with regard to that. For PHC fund and DCCIF, in future, I guess there's need to explore the innovative financing sources. So where we could have some levies, let's say on alcohol, or that are targeted towards whether it's emergencies or particularly primary health care fund, beyond just the general taxation. And then in terms to ensure that their funds are sufficient, there's need to tighten claims process so that there are no leakages, and also ensure that monies are unlocked in terms of verification of claims, because one of the challenges that leads to delays in disbursement is where claims are rejected. So there is need for to actually tighten that entire process. I think the big one for benefits package, sometimes the benefits package, in our case, obviously, we have what is called the benefit package for Kenya and Tariffs Advisory Panel that's supposed to review and advise on the benefits package based on evidence, obviously, demography, epidemiology, etc. So that panel was inaugurated, I think mid last year. So they should regularly review and adjust benefits to align actually with actual collections in the pool, be insulated from political interference. And the main question here would be just to use cost effectiveness and affordability criteria. But the big one is to align or rationalize the package to match the availability of resources. So there are certain ways. I know one of them is actually capping, where I saw for oncology or cancer, whatever, it is capped. It has its own challenges, but that's one of the ways of dealing with the a package and based on how much resources we have for that. Administration is the final one. Yes, so here it's largely just strengthening the system that exists in terms of integration with Kenya Health Insurance, in Kenya Health Information System, the SHA members registry, county facility electronic medical records, etc. So that integration is important, just to ensure that the system works seamlessly. I mentioned about the rejection of claims. Part of the reasons why they are rejected is because of user challenges. So that continuous training is important. Government also needs to implement a child policy on mandatory staffing, and also partner with other institutions for continuous professional development. This is actually important. It helps with ensuring that those facilities that are contracted have the right number and mix of staff. Yeah, the rest is just basically the need to strengthen oversight mechanism. So as I mentioned, currently SHA is both a regulator and a purchaser. So in the short to medium term, one way to mitigate this challenge of conflict of interest and accountability concern is to strengthen the oversight mechanism, but there is need to consider long separation in the long term, and this will actually improve the sustainability of SHA. Yeah, the other one is just basically the need to, because the biggest challenge we have, one of the biggest challenges besides financing is the claims and reimbursement, management of claims and reimbursement. So there is need to institutionalize what is called a claims of oversight unit and have some kind of a tracking dashboard so that whether it's facilities or even the public can track the claims in terms of the claims submitted, the payout, those that have been approved, and so on. And also there's need for that regular report to show the performance, so that government does not just mention the claims that were submitted, but there's need to go all the way to showing what was rejected by which by facility level and the payouts, and so that even one can compute the payout ratios. So in totality, that will also help in terms of just building trust amongst the public. Yeah, so thanks. These are the different materials that we referred to. Yeah, so thanks. I know, sorry, this has taken a bit of time. Yeah, over to you, Chacha.
Thanks, John, and thanks for the beautiful work. It's been great. I know we have overrun time, so we'll have a brief plenary session for anyone who might be having any questions. Please feel free to raise up your hand and mute, and then we'll be able to accord you an opportunity to raise out an issue. In the meantime, allow me to go through the Q&A to see what we have. First, going through our charts, of course, I don't see anything on the charts. On the Q&A, yeah, there's a great conversation happening here. Yes, there's one participant called Fiona who has asked, what alternative financing models could reduce pressure on the exchequer? And should shift be interpreted as a policy ambition? Is it a good policy constrained by fiscal reality, or a fiscally constrained policy being politically oversold? I've seen significant attempts from Dan trying to respond to that. Probably I haven't seen another question coming through. Yes, Fiona. Allow me to put this question this way. What is ailing SHA, if I could put it that way? And of all the interventions being recommended, and I'm glad my colleague John has touched on some of possible mitigation factors. I think the biggest challenge or the elephant in the room is, how do we have the biggest part of the population, which is in the informal sector, actively enrolled in SHA and making their contributions? I think that's one of the biggest questions before we even look at other alternative funding sources. I saw a tweet from the PS Medical Services, as at last week, SHA had managed to do about 7.6 means testing to Kenyans. So a quick question came to me. If we are at 7.6, and we all know for the working class population, about 80% are in the informal sector. So we have just done 7 million. In a population of about 5.8 or so million Kenyans, we still have a lot of ground that needs to be covered to have sufficient resource base. And of course, the other approach is Fiona, probably the government could look at donors, of course. It could look at looking at gifts, donations, or sometimes do what John mentioned in the presentation, of course, sin taxes, of course, trying to tax alcohol, tobacco, beer, of course, to address the primary health care and the chronic condition cover, of course. But again, as we proceed, it's good to also appreciate that This is in the making. SHA is still growing, as in we are still in the development stages of implementing SHA. And so, being an evolving system, it has maturing gaps that will be evident. I don't mean to say that is excellent as it were, but we are acknowledging the fact that there's a little bit, there's still more work that needs to be done to make sure fully functional and to be able to serve its purpose. Of course, the intention was to have it for poor. We are yet to get there. Yes, and thanks, Dan, for the feedbacks you have presented on the chat box. And I like the last one. So health governance in terms of SHA-SHIF is another barrier to access. Well, that will be a good discussion for another day. It will be an interesting perspective to look at. That's all I can respond to. And Fiona, I'm just allowing my colleague John to get a cup of water or a glass of water to continue. On the chat box still, I don't think I see anything. On the Q&A, I don't see. Oh yeah, speaking analysts here asking, hi, could you expand on the mean testing part for a semi-layman perspective? What is it and its usefulness? I'll pass that to my colleague John to pick that up as I check on if there's anything else. John, could you comment on what is the mean testing?
Yes, can you hear me?
Yeah.
Yeah, so the mean testing is actually an approach that is used. It's a common scientific approach used by governments in terms of computing an individual's ability to pay, and it's actually used in our case. Obviously, you can see for the salaried, the individuals who are registered with SHA, they pay actually 2.75% based on their gross salary. But those that are not salaried, so those in the informal sector that either do not have a pay slip per se, the government obviously had to compute. NHIF had a figure, was it 500 for those in the informal, a flat figure. But this one is a way fast of establishing an individual's ability to pay, and then based on that, or just basically their income, and it uses the mean testing looks at household characteristics. So, for instance, it looks at where one lives, whether the house is the kind of roof, tiling, etc. And then it also looks at other characteristics. And the idea is to use those ownership of assets, whether it's cows, vehicles, etc. And the idea is to use that to be able to compute, to gauge one's income. And then based on that, then if it establishes that one's income per month is 10,000, so the premium would actually be 2.75% of 10,000. So of course the law provides that the minimum premium is 300 Kenyan shillings. So that's what basically the mean testing tool is. Now, what we are proposing now, the mean testing in our case can also be to make it more accurate, because we still have weaknesses with our mean testing in terms of validation of the information that people give. There are certain biases. Also, it's not very clear the frequency of this mean testing because one's income level may change, let's say 2 years down the line. So if SHA is still using the same, saying that when they the mean testing was conducted, and it shows that my income is about 10,000. It is not very clear when that when the next test will be done, because my income level will be may change, whether going up or even down. It may even decrease. So so there are certain challenges that we have with this mean testing, and those challenges actually lead to what is called inclusion exclusion. So whereby certain people are either excluded erroneously or included again erroneously. So like including somebody who is maybe even the way the mean testing was done, you find that somebody's income was not computed in the right way. But this testing is also accompanied by the process of identification of the indigents or the people that are supposed to benefit from the subsidy program. So again, that process has its own challenges, and so there's need to ensure that there's proper targeting, so that we don't have people who are not supposed to benefiting from this subsidy program. So that's what the mean testing tool is. So it can be combined by certain things, made a hybrid, like where qualitative information either from the chief or other platforms can be used to just confirm whether what we see in terms of figures combined with the other qualitative information provides an accurate information on one's ability to pay. So that's basically, so there's need to review that and strengthen the tool. And then going into responding to Fiona's questions on alternative financing. So of course, the SHA's design and model is as a mixed, it's a multiple pooling. We have 3 funds. One is contributory SHIF, and the other 2 are tax-based. So that's a good mix. And of course, on paper, there are other sources. So already in terms of a wide range of sources of financing, from a design perspective, this model already incorporates that. So I think the emphasis is not necessarily even on those alternative financing options, but basically on addressing issues of sufficiency based on what I mentioned, and I think also Chacha mentioned, the need to increase, or they are doing the things that I mentioned that will go towards improving compliance levels from the informal sector members. That's actually the most urgent thing that SHA needs to do. So the mean testing and other ways is one of those. So I think the focus should be there, not necessarily looking at the alternatives. The alternatives may come in for the primary health care fund and the emergency chronic and critical illness fund, which are financed from the exchequer, tax-based. So that's where maybe there could be an exploration. Again, that should be evidence-based of using sin taxes and so on, excise duties on alcoholic beverages and the like. So those could be explored. But I think the main emphasis is on increasing compliance, but also rationalizing the benefits package to ensure that it's commensurate to the resources that we have as a country and the capacity of SHA. So in our case, obviously, the benefits package is quite ambitious. And just to mention, social health insurance schemes, the way they are supposed to be designed, they should be, at the bottom line, be based on a country's socio-economic and political context. So that should be the guiding principle. in the design of ships, so that one can figure out how a country can figure out how to face how to enhance the package benefits package as the economy grows and so on. But given that what we have, I think I've already mentioned some of the recommendations even before looking at the question of alternative financing. Chacha, are there other? I'm not able to see.
Yes, John, I think we'll take the last one from Olungabutu. What can be the solution to the claims issues? It doesn't augur well that every time there is claims of fraud by the government, it is a challenge with the system. Well, yes, John.
Okay. Yeah. So yeah. So that's I think it's a big challenge. This has been a major challenge for SHA. And one of the key, of course, there's no silver bullet to it, but one of the key things that need to be done in order to reduce the cases of fraud is obviously strengthening the SHA system. And that is actually, there are certain gaps. Yes, there's quite a bit that SHA has done, working together with the Digital Health Agency in developing that backbone, digital technology backbone. So the idea is, unlike what we had with NHIF, is to prevent and ensure that resources are not lost. So in our case, whereas we don't have like information, but I think what was the report shows that, of course, the cabinet secretary mentioned that out of the 11 billion plus, that was, whereas it was reported as lost, but the cabinet secretary mentioned that it's only about a billion plus, 1 billion plus is what was actually lost. And what they mentioned is that they will follow up with those facilities and the people that were involved, or actually hold back the claims, the valid claims from these facilities, use that to pay. And of course, it's a process for, there are some that people have been taken to court and the like. But I think one of the things that we can see, I don't remember the number, is that there are a number of cases that have been flagged out. So the idea is to ensure that this system is more preventive. So I guess there is need to plug in some of the gaps that the system has, and so on, but also maybe just increase the convictions and deterrence. But the idea, the main idea is just to strengthen the system so as to reduce the cases of fraud. Yeah, so I think that's my main response. There are obviously certain other things that are not necessarily fraudulent, but they delay the disbursement of resources to facilities. And I think those are the ones that need to be addressed, where the users need to be trained. So there's need for support for users in terms of lodging of claims as well as to lead to delays. Of course, the law provides that I think 14 days for appeal. All these things are intended to ensuring that facilities liquidity is not affected. Yeah.
Thanks, John. Thanks, John. I think we have overrun time, but I wouldn't close without acknowledging current Sunday's comment, of course. Yeah, Sunday, there have been reports made by whistleblowers on the use of SHA system by different facilities. Documentary done on Nakuru, for instance, but nothing is done to address these reports. As CSO actors, what do we do about these and the piling cases reported with no action taken? Sure, it is a valid concern, of course. And we continue to keep the conversation going and then get to the authorities to make sure that they take action on some of these happenings. And they had, as John had mentioned earlier, this is a system under construction. We will be undergoing a lot of teething problems and challenges. I'm not sure when they will be done, but then you are right. We have to do something, especially in the civil society and among our interventions. Yeah. I don't think there's any other question. Oh, there is one. My colleague whispers to me here, there's one. Is it on the Q&A or on the chat? On the Q&A, checking for one last one, John. Just bear with us.
Okay, that's fine.
I could you know that one is done. In 1 minute. I don't intend to take long on this. Yes, there have been reports made by whistle. Yeah, I have read this one. Yeah, I've read this one. Thanks. My colleague was drawing it what we just discussed. Thank you. So thanks, John. I think I'll request that we stop at that. SHA is an ongoing conversation, and we all have to keep engaged as we move forward. Please, to all participants, this webinar is recorded and it should be posted on the IEA website. If you wish to make reference, please feel free to do so. Similarly, please note that IEA is a membership organization. So for those new members who have joined our webinar, probably today is the first day, please feel free to get in touch with our communication team. They might guide you on how to join as a member of the IEA. That's said and done. Let me take it back to John to give a final remark. Back to you, John.
Okay, thanks. Yes. Again, in relation to this comment by Sadia, so I think there's need for us to continue to engage as CSOs, obviously. There are many reports surveys that have been done. And the main challenge, particularly when it comes to claims, is that we do not see performance or regular performance of the claims and management, the claim reimbursement process. So, for instance, as I mentioned, besides what is captured by the Office of the Control of Budget, or maybe even the Office of the Audit, that have been submitted so far by all facilities. I mean, by facility level, vis-a-vis what rejected, what's approved, what's considered, and so on. Because that information will be used in also just understanding the challenge with claims and why the fraudulent cases are arising. So there is need to continue to demand that these reports and some kind of a dashboard is made public, because this will not only increase transparency but also build trust, public trust with the system. But I'm sure this is something that's available internally at SHA, but it should be made public. So no doubt, yes, the SHA system is still evolving, is still maturing, but you can see its work, it's cut out in terms of the need to address the many challenges that you can see across these four components of any social health insurance scheme. The main one being on the question of sufficiency of resources. And then when it comes to administration, the main challenge again is with the claims and reimbursement. And the breakdown of those two actually means that the patients or service delivery of services will suffer. So yeah, so thanks a lot. So I believe that this has been useful in terms of just pointing out things that we can individually run with for discussion in our own public spaces, but also engagement with the government officials, whether at the national or county level. So I can see the slides have already been shared, and this report, this brief will actually be posted. So look out for that on our website. So this again, next week we'll be having a media briefing just to share this in terms of just enhancing, widening the outreach and discussion, fostering discussion on the question of whether SHA is working as desired or not. Otherwise, thanks a lot, and thank you for the feedback. Yeah, back to you, Jotham.
Yes, thanks, John, and we apologize for having overrun time. And as we conclude, let me say thank you to all those who joined, and a big thank you to our donors, FCDO, who through their support, they have made this work possible. Thank you so much, everyone, and enjoy your day. Thank you and goodbye.